At one kidney transplant program in Australia, dozens of patients were rejected from the waiting list solely because they were actively smoking. Many were younger and had fewer other illnesses than patients rejected for different medical reasons. The policy was intended to protect scarce donated kidneys. But researchers found something uncomfortable. Transplant centers across Australia and New Zealand did not all use the same rule, and support for quitting was inconsistent. Imagine being one of those patients. Your kidneys have failed. Dialysis controls your blood for hours at a time, several days each week. A transplant may offer a longer and freer life. Then the committee says no, not because the operation cannot work, but because you still smoke. Now imagine there is one kidney and two medically compatible patients. One smokes, the other does not. Should the smoker get the last kidney? The immediate reaction is often moral. One person protected their health. The other knowingly inhaled something dangerous. Why risk a donated organ on the person who may damage it? But transplant medicine is not supposed to measure virtue. It is supposed to estimate benefit, risk, urgency, and fairness. The medical concern is real. Smoking increases cardiovascular disease, cancer, lung complications, and problems with healing. After a kidney transplant, patients take medicines that suppress the immune system. Those medicines protect the new kidney, but they also increase vulnerability to infection and some cancers. Adding tobacco can compound those risks. Research in kidney recipients has linked smoking with worse patient and graft outcomes. A major international guideline from KDIGO reports that a smoking history above 25 pack years was associated with a 30% higher risk of graft failure, mainly because of increased death. It also reports that people who had quit more than 5 years before transplantation had a substantially lower risk than continuing smokers. That gives transplant teams a strong reason to care about smoking. A donated kidney is not an ordinary treatment that can simply be manufactured again. Someone died, or a living donor accepted surgery to make it available. Thousands of other patients may still be waiting. The argument for giving priority to the non-smoker is therefore about utility. If one candidate is more likely to survive the operation, follow the medication plan, and keep the kidney working for longer, choosing that candidate may produce more years of life from the same organ. Yet utility is not the only value in transplantation. Waiting time matters because people should not be endlessly overtaken by candidates who look slightly healthier. Urgency matters because a patient may be running out of safe dialysis access. Equal respect matters because a health system should not abandon people whose illnesses are connected to addiction. A fair allocation system has to balance benefit with justice rather than maximizing one prediction at any cost. There is also a practical question about behavior after transplantation. If a patient cannot stop smoking before the operation, will they stop afterward when the stakes are even higher? Some programs use a period of abstinence as evidence that a person can sustain the changes needed to protect the graft. That sounds reasonable. But it can slide quickly from prognosis into punishment. Nicotine dependence is an addiction, not merely a bad attitude. Tobacco products are engineered to reinforce repeated use. Quitting may require counseling, medication, several attempts, and a stable environment. A patient who fails once is not necessarily careless. They may be dependent, stressed, poor, surrounded by smokers, or living with untreated mental illness. Smoking is also socially patterned. Rates are often higher among people facing poverty, unstable housing, limited education, or physically demanding work. A rigid smoking rule can therefore amplify disadvantages that already shape who develops kidney disease and who reaches specialist care. Then comes the consistency problem. Many patients reach kidney failure partly through behaviors that affect health. Poorly controlled diabetes, missed appointments, unhealthy eating, alcohol use, or failure to exercise can influence outcomes. We do not usually ask whether every patient lived perfectly before offering treatment. If smoking becomes a moral disqualification while other risks receive support and management, the policy may be less fair than it appears. The United States Transplant Ethics Framework warns against excluding candidates simply because of a potentially harmful behavior. The connection between a behavior and transplant failure should be supported by evidence. The policy should consider whether the behavior is ongoing, whether effective treatment is available, and whether social conditions limit the patient's ability to change. In other words, a medical risk may be relevant without becoming a judgment about who deserves to live. Current kidney guidance offers a useful middle path. KDIGO recommends that candidates avoid tobacco before and indefinitely after transplantation. It recommends access to a cessation program and at least 1 month of abstinence before waiting list placement or a planned living donor transplant. That is a serious condition, but it is not a declaration that anyone with a smoking history should be excluded forever. The distinction matters. A former smoker is not the same as a current smoker. A person smoking 2 cigarettes a day is not medically identical to someone with severe smoking-related lung disease. Nicotine replacement under supervision is not the same as continuing to inhale cigarette smoke. And a patient who engages with treatment is different from one who refuses every attempt to reduce an immediate surgical risk. Living donation introduces another ethical wrinkle. If a relative freely offers a compatible kidney, should the state still stop the operation because the recipient smokes? The organ is not being taken from the general waiting list, but the donor is accepting risk. A transplant team still has duties to both people and may refuse surgery if the expected benefit is too low. Even here, however, a blanket moral rule is weaker than a patient-specific medical assessment. So what should happen when there really is 1 kidney and 2 candidates? First, allocation should use transparent medical criteria, not a hidden vote about character. The relevant question is how much current smoking changes the expected outcome for this patient. After considering age, heart and lung disease, cancer risk, immune compatibility, waiting time, and urgency. Second, any abstinence requirement should come with real help. Telling a dependent patient to quit without counseling or medication is not a treatment plan. It is an obstacle. Programs should offer evidence-based cessation support, explain how abstinence will be verified, and give a clear route back to candidacy. Third, deferral should be proportionate. If several weeks without tobacco meaningfully reduce surgical risk, temporary deferral can be ethically defensible. Permanent exclusion based only on the label smoker is much harder to justify. Fourth, the same standards should apply to everyone. Wealthy patients should not be able to move between centers until they find a more permissive rule, while poorer patients remain trapped by geography. Variation between programs can turn medical eligibility into a postcode lottery. Programs must also be careful with testing. Cotinine can reveal recent nicotine exposure, but it does not by itself explain whether exposure came from cigarettes, vaping, nicotine replacement, or even substantial secondhand smoke. Testing can support an agreed treatment plan. Used without context, it can turn a therapeutic relationship into surveillance and punish honesty. There is one more uncomfortable point. The phrase last kidney makes the decision sound like a contest between 2 strangers. Real allocation is more complicated. Blood type, immune matching, time waiting, pediatric priority, sensitization, geography, and expected benefit all matter. Smoking may be one factor, but it is rarely the only one. My view is this: a smoker should not be denied a kidney because doctors believe the person is less worthy. Active smoking can justify temporary deferral when it creates a substantial and immediate medical risk, especially if the patient is offered meaningful help to stop. If 2 candidates are otherwise truly equal and current smoking clearly predicts a poorer outcome, giving the kidney to the non-smoker can be justified as stewardship. But the decision must rest on evidence, not blame. The purpose of a transplant program is to save lives and use donated organs responsibly. It is not to reward perfect behavior, because no patient arrives with a perfect life. So where would you draw the line? Should active smoking reduce a patient's priority, delay listing until they quit, or have no role at all? And if smoking counts, which other behaviors should count too? I am Dr. Adrian Mercer. Thanks for watching, and stay healthy.